Okay, Raju. Raju, you're here.
I'm here. I made it.
I gotta say, we started this with Raju, I guess more than 11 years ago, and I can still remember, like, Raju, give me a list of names for the foundation, yes or no? So he sent me a long list, and I said, no, I don't like this, I don't like that. And then I think he was tired of me asking. I said, okay, Global Men's Health Foundation seems fine to me. And since then, uh, he has been there with such humility. We don't see humility anymore, It's very, very rare. You are humble. And we start going into a fast track, trying to present the world with how important it is, men's health, is gender medicine. And I remember each time I had a meeting like this, which is so complex, I was desperate. So I said, Ryan, I don't know the names. My English is bad. What I do, because I would go to the internet and look for the conferences of the people I wanted to invite. So I would change the name of the conferences a little bit. So he said, can I catch an airplane and go over you where you are? And she said, okay, Ingrid, come, we will do it. Be prepared for a whole Saturday. And when you leave to Panama, next day, it will be fine. And it happened. So what a person, what a heart to spend with me just because I couldn't do it alone. So I'm blessed. Come here, dear Raju.
Thank you.
You are one of the best things that happened in my life.
Oh, thank you. Me too. Thank you so much. I mean, you've done a tremendous job of putting the Men's Health Initiative around the world. And as we look at artificial intelligence and the chat GPT that we just heard, what is important is that we have to be training our future surgeons. So, as being part of the ACGME sponsored training programs, I've been doing this for well over 30 continuous years of being the program director and stuff like that. So, for those who don't know, there are several who know how this is done, but for those who don't, it's important to know that training starts young. So if you have a good foundation, then the residents can move to the next level of excellence, whether they go into artificial intelligence sometime or endoscopy or open surgery or whatever. It is the basic training that's important. So we have to train our residents to be the best that they can be, whether they're going to go into private practice or academics or at different sites that they have now. Uh, because this is the formative years. They are usually between the ages of 24 to 34, depending on when they match. But we have to have expectations, supervision, and a standard training for these residents. So in the US, we are very much tied to the Residency Review Committee and the ACGME, which is for the Council for Graduate Medical Education. They manage all the residency programs in the US, family medicine, cardiovascular, urology, you name it. The purpose is to make sure that it is uniform. Whether you're in California or New York, it's got to be uniform. As far as recruiting residents, they have got a set of rules that you have to follow. You can't be an outlier. Training requirements for each year of training, first year, second year, third year, fourth year, fifth year. There has to be a centralized office at each site. The program director and the program coordinators have to monitor all the activities for these patients. All the data is maintained in Chicago. So If they want to know what I did when I was a resident, it's there. So that's why it is very standardized and expectations. So how does the program at USC or in New York go? They have to have certain conferences which are standard, evaluation of the residents. We have to also look after the residents' wellness. Are they overworked? Are they working more than 80 hours a week? The research projects, quality improvement projects, and also their in-service academic work. So all this is monitored, and this is actually monitored also from Chicago. Right now, there are more than 150 certified training programs. It can be as high as 6 per year, but there are very few one a year, but most of them are either 2 or 3 a year. And the curriculum has to be literally certified by the ACGME. So if I want to start a program, see, I think I'm at St. Vincent's Hospital, I want to get going, then I need to make sure that I have a clear definition of the different sites of training. How many board certified faculty do I have? Do I have research space? How many square feet of research space, equipment available? What are the number of patients we have? What are the number of index cases? I show that in a few minutes. Because if you do 400 TURPs, but only 6 radical cystectomies, you will not be certified. So you need to have a certain number of cases that are available. The GME office, the program directors, the ancillary staff, program coordinators, we have to keep all the records. They're submitted every year, but we got to keep the attendance sheets, conference records, evaluation of the residents, evaluation of residents by the nursing staff, the OR staff, patients, evaluating residents. So this is a lot of paperwork that has to be maintained. The RRC will have periodic site visits if needed, or if there is any problem. If there are any complaints, then the RRC will put a given program on probation or warning, or sometimes temporary shutdown until they get their act together. So there has to be a set level of circumstances where the PGY 1 can go to 2, and then 2 to 3, and so forth. We have to turn in the surgical logs, robotic, endoscopic, all that. Their residents' updated CV every year, the research projects and what they've been doing, quality improvement projects, meaning, for example, why is it that we're having in this particular site so many cancellations? So that's a project that is called a QIP, so they can review that. So on and so forth. You can see they survey the residents, they survey the faculty. So if you want to complain that the program has issues, they can do that. But then if there are complaints, the RRC takes it very seriously, and then they will come back and look at that again. If I have a program that is doing well, it's accreditation with no citations. Or they may say you're accredited, but you got a problem with duty hours, or a problem with inadequate faculty, or conferences. That's called citations. Next year, it better be corrected. Otherwise, you'll go on probation, or a suspension, or hopefully not withdrawal of accreditation. So these are the levels that we have to go to make sure that our residents are trained and are able to maintain the future of urology. If you are on probation, then the residents who are looking for a job say, well, that's is on probation, I don't want to go there. So it's very important to make sure that your program is fully certified. The federal government pays for it. So for each level of training in the U.S., the U.S. government subsidizes each resident $110,000 a year. So when I finish 5 years of training, the taxpayers in the U.S. have spent $550,000. So That's why if they're giving the money, the expectations are that you better be standardized. So this is how the training is in the US. That goes for the salary, for the program director, for the coordinator, the GME office, and that averages to 110,000 per resident per year. It's highly competitive. To be a urologist is very competitive. We have a separate match. So the medical students have to do research, make sure that we consider them eligible of good standards to be in urology and carry on our successful training programs. So these are the index cases. So every year we have to send to the RRC each resident's surgical logs. So when you look at that, for example, let me go back. You can see, it doesn't focus well, but it goes on to everything from urethroplasties to the robotics, the pelvics, prostate, transurethral, percutaneous, the kidney stones, etc. So they have to meet or exceed the expectations. So if not, then they will question us saying, how come you are inadequate in a particular category? If you want to expand your program from 2 residents a year to 3 residents a year, they will look at all these numbers. If you have enough of cases, enough faculty, enough of research and stuff like that, they will approve after careful considerations. Residents are given the survey. So are they feeling like they're getting a good education? Are they getting wellness programs? Are they being allowed to go to meetings and so on and so forth? If they find that the resident survey has complaints, then your program will be investigated. Actually, there are some of the big programs have been put on probation. East Coast, West Coast, the big programs recently have been on probation because of complaints from the residents. So it's important that we maintain that. And for example, here, they talk about categories in their well-being, categories in their education, categories of supervision, are the faculty available, and so forth. So this is the faculty now. Are the faculty given enough resources? Are they given personnel, laboratory space, coordinators, etc.? So all this is maintained by the RRC on an annual basis. And all of this is maintained in such a way that you cannot fall outside the bar. You got to be on an average. If you drop, then they're not happy about that. Relevance to the non-US surgical program. So, for example, if we say, I'm in Panama, I want to make sure that we meet standards. This is a good basis. Now, it's true that you can't have everything everywhere. For example, I can tell you, in 2008, I was asked, do you have a robot? 2008. We had a robot since 2002. So what I'm saying is, you can't expect that in every country in the world, but this could be a basis of making sure that we are able to standardize our training. It is important that the surgical cases are done by the resident. In many countries, the attending will do the cases, and the residents are watching, either on the monitor or watching. Over here, the majority of the cases have to be done by the residents. We got to provide them travel to meeting feedback. This group of residents now, they want feedback. How did I perform in the last case? What was the technique, the coordination, the knot tying skills, etc.? They expect that. So in conclusion, what is important is to have standardized curriculum, supervision, evaluation, feedback, so that we can put these future surgeons on the right track. Thank you. Once again, thank you, Ingrid, for setting all this up over the years and continuing it. Thank you.